It's the time to bring in the big guns, the imagings. You might be wondering, why do we even need imagings? Our patient presented with abdominal pain, and we did the serum lipase and amylase, and they were raised. We made a diagnosis. But now, why do we need any imaging? Sometimes we need imaging to establish a diagnosis, and other times to identify cause, complications, and there may be those nasty stones, the gallstones. For them, we need the X ray or ERCP. And the CT scan is best for complications and to assess the severity. So I have a question, you guys. Our patient had symptoms, and she had raised serum amylase 3 times normal. Okay, now do we need any imagings to confirm our diagnosis? And if you say yes,
Are you trying to bankrupt this hospital with your incompetence? Patients rely on us for proper care, not for you to play around with resources like they're toys.
that's what you're gonna get. Because we only need 2 out of these 3 to make a diagnosis. So the patient had abdominal pain and the serum lipase was 3 times normal. So we don't need a CT to confirm the diagnosis. Also, the patient came in emergency. She's in severe pain. So why would we do a CT to confirm diagnosis and waste time and resources? Okay, so we have a lot of images and we have to choose which ones are necessary in this case, of which we must do a baseline x-ray to see what's going on inside, and then an ultrasound. We would do an ultrasound of all the patient of acute pancreatitis. Then we have a CT scan, but it's not so important at this time. I guess they're having a good time out there. Never mind. So I ordered an abdominal plane x-ray of my patient. So here's what I got. So I can see the transverse colon, the intestines, but there are no pancreas. What am I supposed to do with this? Oh yes, I remember. Pancreas are present behind the stomach. X-ray cannot show us the pancreas. So what are we supposed to see here is an abrupt termination of gas within the proximal colon at the level of splenic flexure. And inflammation is no doubt going on in the pancreas, and this inflammation can cause a spasm in the colon, as we know that it is located near the pancreas. So there's a specific name for this sign, and I think she's cutting something, and colon cut. Yeah, it's called a colon cut off sign indeed. I hope you won't forget it. Okay, so abrupt cut off of colonic gas. No, so dull. Once upon a time, the inflammatory exudate escaped their wicked house of the pancreas and moved towards the colon. The colon panicked and had a twist, but thanks to the phrenicocholic ligament that saved it and anchored it towards the diaphragm. Now, that's another sign that we can find in a patient of AP. But I want you to search what this sign is called. Should I introduce you to our non invasive, cost effective, quick to perform, very valuable real time imaging, the hero emergency tool, the ultrasound? All of us are on the same page if you cannot appreciate a single thing in this picture. Understanding an ultrasound is crucial, especially in the emergency situations like this. And we have to perform an ultrasound on all the patient presenting with AP. We can skip an X-ray, but we can't skip an ultrasound. So let's break it down together. A picture of an ultrasound, an abdominal ultrasound taken from a normal patient, and you can appreciate the head, body, and tail of the pancreas. Here, I want you guys to have a look on the size of the pancreas, and there is a peripancreatic fat around the pancreas, the superior mesenteric artery, the inferior vena cava, and the aorta can be visible. And if you guys do not remember the normal anatomy, here have a look. Compare the size of the pancreas in both pictures. You would find a swollen pancreas and peripancreatic fluid, and the peripancreatic fat is also swollen, which is called peripancreatic straining. Should we use our biggest weapon, the axial abdominopelvic CT with IV and positive oral contrast now? It's a saying that the mightiest weapon should be reserved for the darkest hours. So, what's the darkest hour? Our patient came at almost 10 p.m. and now it's 1 a.m. Do you think the time has come? No, it's not the right time, because the optimal time for doing a CT scan is almost 48 to 72 hours after the initiation of symptoms, because otherwise it may overestimate or underestimate the amount of necrosis, which is a complication present. So, as I already told you, the CT scan is reserved to check for the severity and detect the complications. We manage the patient for 48 to 72 hours, and if the clinical status of the patient is deteriorating, then we go for a CT scan. Anyhow, to have a basic knowledge, we managed to get a CT scan. Our things we can appreciate are pancreas, spine, kidney, liver, bowel, which appears black. The ear, fat, tumor, and ischemia appears hypodense, which is darker, i.e. black, while the blood calcifications and IV contrast are hyperdense, which appears lighter on a CT scan. So the CT scan shows inflamed pancreas as in the ultrasound and peripancreatic fat stranding. So as I already told you that we have to tell the severity and the complications. So to assess the severity, we have this index called BULT whatever. So the peripancreatic fat staining is present. So we give a score of 2, and it falls in mild acute pancreatitis. Last thing we will discuss here are the complications. So there are a bundle of complications that we may see in acute pancreatitis, but the complication that we can appreciate on a CT scan are cyst, pseudoaneurysm, infected necrosis, and fluid collections. Okay, let's look at each of them and see how a CT scan shows them. So, pseudocyst. Disruption of the pancreatic duct causes fluid collection, and if this fluid remains there for more than 4 weeks, then it will be walled off, and there will be a pseudocyst, which you can appreciate here in the CT scan. If our patient is unlucky, then he may develop an infected pancreatic necrosis. And as you know that when there are bacteria, they produce gas, and the gas is hypotension. Non-enhancement of a portion of pancreas show necrosis. You can appreciate the bubbles on the CT scan, and these bubbles indicate an infected pancreatic necrosis. Exudates from the inflamed pancreas erodes the nearby blood vessels, and there is a leakage of blood, and it forms a hematoma, and it looks like an aneurysm, so it's called a pseudoaneurysm. Arrow is showing an area of pseudoaneurysm, and you can compare it with the aorta, which contains blood, and I told you that the aorta, the blood is hyperdense on a CT scan. So yeah, if the inflammation is not settled after the initial episode, or there are multiple attacks of acute pancreatitis, then it may lead to chronic pancreatitis, which can be seen as the areas of calcifications and duct dilatation. But keep in mind that the serum lipase will be normal. So, yeah, that's it for the imaging.